But when you talk about, you know, PTSD and all of these different things that is going on in the world, let's remember that the mitochondria does get damaged in this process. Even if it has good genetics, the function goes down. And what we do know now is that dysfunction is passed down 1 to 2 to 3 generations. The genomics of what is happening now, our children do pay for. We know that from Holocaust survivors, diabetics, we've studied that genomic over and over. But with mitochondria, at least for me, it gets so complex so fast that I just wanted to start back a little bit. You know, how did we get here? Are we really looking at mitochondrial DNA or DNA outside of it to see how it works? And so I just wanted to give you a bit of a mitochondria primer. And it really started with, there was a bacteria that had very little power, and it was invaded by a bug, and that bug had a lot of power, and it stayed and it lasted, and it was a development. It's almost kind of makes sense that we are such yin and yang creatures, because literally we were invaded by a power cell, or they invaded us, or we were the invaders, depending on if you're whatever it is. And then it lasted, and it took 2 different pathways. So the first, they call it the endosymbiotic event, because we have to give it very big words just to make sure that we need to learn new curriculum for stuff. So the first endosymbiotic event involved that energy, cell coming in. And then the second is what split us off into the plants, where you had the photosynthetic bacterium then go ahead and invade as well. And that's what gave access to the photosynthetic eukaryote and back to the prokaryote as well. I find that fascinating. And that's why we have this separate DNA ring that is in there, and I love these simple drawings. I'm a dumb old cardiologist, and I am so over my head in most things these days that I like these simple drawings, and it just shows there specifically that DNA ring that is in there. Now, since it's providing 90% of our energy, that DNA ring is pretty damn important. And when you think about it, that DNA ring there is that, again, this was an autonomous living creature at one time. I don't know if you know this, or most people I think do at this point, but mitochondrial DNA is only inherited from the mother. So the mother of all of us is an African woman. Her mitochondrial DNA is literally, yes, it has changed some through the years, but very, very little. The mitochondrial DNA in sperm is in the tail, and so the head pops into the egg, the tail drops off, therefore we inherit only from the mother's side. So, by the way, this is how we do the ancestry stuff. It is largely through mitochondrial DNA passed down from mom, and that's why we can track it so much. So this is mitochondrial DNA. Memorize it. There'll be a test later, right? One of those things. But when I look at it, it's really cool, but does it help my patients? No. I mean, I can't clip out a piece of mitochondrial DNA. These are still tendencies. When I ran my 23andMe, it said I had brown eyes. I have green eyes. It said I was tall, and I'm really pissed about that, by the way. My brother got the height, and he didn't want to play athletics, and I got the short, and I had short man's disease. Still recovering. I became a cardiologist. That did not help short man's disease, as we all know, dealing with cardiologists. But that's mitochondrial DNA, and it's really neat, and you see it associated with all these disease syndromes, but does that really help us as clinicians? I mean, you look at this and go, okay, with this mitochondrial piece of DNA, do I change my treatment? Because the purpose of all lab tests is to change treatment. You run a CBC and you run an expanded panel. You run an expanded panel, and it shows that they're low in iron, that they're anemic, and you give iron. So this is really cool, but it's classroom. It still doesn't help us with our patients. When we go on, we look at more specific conditions. Again, very sort of broad spectrum stuff. Eyes, nervous system. I mean, I got to put my glasses on for some of these big words here. I mean, I don't have a lot of patients with myoglobinuria. And I do, if it's truly a DNA problem, it's going to be tough to deal with. So it doesn't really clinically support us that much. And that comes down to this genomics versus genetics issue. Genetics, the expression, study of heredity, study of function of single genes. Genomics being the collective genes. And right now, we don't know what to do with the DNA ring very much in mitochondria. We don't know how to stimulate it, calm it. We don't know a lot about it. We're still outside of that ring. But maybe that's good before we start screwing around with the energy producer. And there's plenty of things we can do right now to really help people. Let's look at the superoxide system. This is responsible, basically the maid service. This is responsible for maintaining and cleaning up free radicals, not just in mitochondria, but throughout the body. Now, this we can work with, and we're learning quite a bit about it. When I'm in think tank work, which is really interesting because they feed you really, really well, like blue chip crab hollandaise eggs for breakfast. The government's got money, man. It is. What do you mean you're not having the blue crab and eggs? It's a little heavy. Can a brother get a yogurt? Something like that. But when I'm in these think tank talks, they're talking a lot about this genetic inheritance and how we have to start looking at these systems more. What I find fascinating is that copper-zinc game. Copper depletes zinc, zinc depletes copper, but yet, together they have to work together in order to keep our mitochondrial function. Now, one quick clinical pearl, most of my heart patients are on zinc. Most of all of my patients are on zinc for a very simple reason. We are the copper state. And let me tell you, copper pushes out zinc. I don't have a lot of trust in nutrient panels. You run them and it says you're deficient in this mineral, whatever. I have more trust in things like taste buds and wound healing and things like that, zinc stuff, sexual function, things like that. But I do think it is an adaptation for our patients in Arizona to use zinc. Anybody else feel that way or use that in your practice that way? I'm a person 1, 2, 3. All the smart people just rose their hands. No, just joking with you. Good, you guys aren't so fried. You guys have had good. That last speaker, and Heather Zawicki is a really smart person. You guys, it was a very, very good day here. But anyway, if you see, this is encoded on chromosome 21. This is not encoded in the mitochondrial ring. This is encoded over in chromosome 21, and it just simply involves superoxide dismutase or the reduction of free radicals to hydrogen peroxide. SOD2 on chromosome 6 is where you're going to get your money's worth. Out of the talk, I think this and GPX1 are the ones we have to pay the most attention to clinically. And at the end of the day, I'm not a scientist. I fake it, but I'm not a scientist. Similar to back here, you go O2 negative, the superoxide ion over to peroxide. You're getting the same thing here, but inside mitochondria. This is what's responsible for working inside mitochondria. And in my heart failure patients, and in my patients that are doing anything chronically, when this is deficient, I change my strategy. We have 3 cases at the end I'm going to spend the majority of time on, because I want to show you what I've learned clinically and what a lot of my colleagues are doing clinically as well to change our treatment based on these things. SOD3, a very similar fact. I want to go back to this. This is a manganese piece. Are we manganese deficient? I don't know. We're about everything deficient. We keep eating. So I was in Iceland. Oh, the minerals in the food. And when you buy a bottle of water, they tell you, don't buy another one, just fill it up from the tap because it's the same thing as the Icelandic water. How cool is that? Don't buy another bottle of plastic. At the store. I just love Iceland. It is such a neat place. But we should probably talk about this. But the minerals. Are we deficient in manganese? I do see people's energy pop up from magnesium, straight manganese supplementation. And that means that it does not have the cofactors to fix SOD2. It is something we need to look at in all of our neurotransmitter formulas, in all of our mitochondrial formulas. How much, who, which chelate, I don't know yet. But manganese deficiency is probably something that we have missed. We know a lot about magnesium deficiency, and companies are doing breakthrough work on it, and calcium, the complexities of that. But manganese has stayed off of the chart quite a bit, and it needs to come up like zinc and other ones. SOD3, we're back to that copper relationship again, I believe. Yes. Again, this is all reduction of superoxide, of the superoxide free radical. So let's go through a few cases here. I want to start with this slide and this slide, which say, who do you run these tests on? This is what's killing the companies that are selling mitochondrial testing. It's your core, right? So is it good for cardiovascular patients? Yes. Is it good for chronic fatigue patients? Well, yeah. I mean, it's good. And it becomes like this thing. Everybody should do this test. Well, everybody does a CBC. And everybody does a chem panel. And everybody does hormone testing now. And everybody goes on. Mitochondrial testing has to go into that category of any chronic condition. Like, do we run hormones on cancer patients? Of course. Do we run hormones on healthy patients? Sure. We were as a screening tool. Do we run them on menopausal patients? Sure. Mitochondrial screening has to be part of our baseline with anybody with a chronic condition. And yes, as doctors, it's like another test, but this is kind of the one we've been waiting for. But I wish we were better at treating it. We're just getting started, but it is a new baseline test that we will need to run on all chronic disease patients. Now, important, what I recommend before mitochondrial testing is stopping anything for about 5 to 7 days that they don't absolutely need. So if they need diuretics or they fill up with fluid, of course don't stop it. If they need pain medicine or whatever, that's fine. But I do like to take 5 to 7 days, give their supplements a rest, meds, depending on what it is, in order to check it. Now, it's not absolutely necessary, but to me, it's a good idea. This is a Lyme disease case. We have a 44-year-old female diagnosed with Lyme with a babesia, fatigue, depression, hormones unable to balance. Now, think about this. They have Lyme infection, but what are their complaints? Their complaints aren't a typical infection. I've got redness, swelling. What are the complaints? The complaints are mitochondrial and neurotransmitter complaints. Fatigue, depression, hormones, low functioning to high. She has chronic antibiotic use, joint pain, neuropathy, insomnia, palpitations. So her problems are obviously a result of the body's response to the Lyme and the body's lack of response to the Lyme. Let me repeat that. Her problems are obviously her body's response to the Lyme and the lack of response to the Lyme. That's what's giving her the symptoms. She can't fight back. Let's see why. So Lyme disease symptoms, early Lyme versus chronic Lyme. I probably don't need to go into that, but I want to look down here for a second, and I want to take you through a little more of a protocol that we're talking about. So as you see, infection, inflammation, free radicals, mitochondrial stress. I want to go through this. This is our new, what we kind of call central dogma of disease and health. So infection, stress, whatever it is, something starts the system off. I insult you, I punch you in the face. Either way, it sets off inflammation. Our body responds. Cortisol goes up. Norepinephrine and epinephrine go up to increase vital signs. But why else do norepinephrine and epinephrine go up? Because they control inflammation. So your norepi, all of your catecholamine system, has to respond to the insult and respond to the punch and come up. With that, our serotonin and GABA system should come up as well. So you now have cytokines that are expressing, you have inflammation. Now, specifically in cytokines, how do they work? They work by utilizing free radicals. Cytokines come in to clean up damaged tissue. They are free radical actors. That's how they do it. So, too many antioxidants acutely in an injury, it is absolutely possible because you'll back off the cytokine's ability to do its job. So you have inflammation, free radicals, and then what does that do? As the free radicals continue skyrocketing, the mitochondria function drops. Now we have chronic disease. That is what is going on. Now mixed in there, of course, when you see the mitochondrial issue, you have two other issues, hormones and neurotransmitters. They are always linked to mitochondria. Mitochondria linked to hormones and neurotransmitters. Always. You always partner those three together. And we have a slide right here with this, showing mitochondrial regulation from the formation of pregnenolone. And I don't know how many people realized it, but pregnenolone comes from mitochondria. So think about a stressed mitochondria. It's responsible for making all the energy in the body. Now it's pushed to the limits. What's the first thing it's going to stop making? Sex hormones. I mean, just like in my life, it's not that important. Huh? Funny? No. It is to my wife. Let's hope it's, we're not going there. Anyway, if you see it's putting out, there's hormones going into it to sense and to help it make things. It is bringing in the cholesterol, and then it's coming out using peroxidase and also making pregnenolone and all of our sex hormones. Same thing, it doesn't manufacture, it can make some neurotransmitters, but generally it regulates the neurotransmitters. If you see through here, we're looking at mitochondria, it'll come in through the free radicals, and that will kick off the system. Regulate hormone synthesis, regulate neurotransmitters. So again, another take-home message is, look, we all need to use hormone replacement. That's not going to go away. But the reason why is because of mitochondrial dysfunction. Yes, xenoestrogens are, of course, a part of it. Why do mitochondria go bad? Because livers are toxic. All that same stuff that we do, none of that goes away. But when we're looking at the actual mechanism, it is mitochondria. So here's some stuff on Lyme disease that's just popping up in the literature that's finally starting to look at mitochondrial function, superoxide production, things like that. This was the patient's neurotransmitters. Now in this case, you're like, well, at least taurine's high. But taurine's high due to inflammation. It is actually a very sensitive and specific inflammatory marker for this patient. So this patient, this isn't a measurement of Lyme. This is what the Lyme is doing to the mitochondria and the central nervous system. And if you look at the sex hormones, pretty well bottomed out. And when we look at their panel, mitochondrial superoxide is elevated, peroxidase activity is elevated. Look at the membrane potential, bad, and the oxidative challenges. And if you see those two graphs on the oxidative challenge, the second one shows that when it's getting really, really hit, it really can't respond. That mitochondria does not have that second gear to really make it respond. Here's the genetics with it. Now I'm going to throw you a little bit of a curve here. So you see that SOD1 increased activity, SOD2 decreased activity in SOD2. So that gets us thinking, when do I give antioxidants then? That's what this is in my crazy brain doing, okay? As we go down, I want you to notice one other thing. The GPX1 gene is okay. The GPX, that glutathione peroxidase gene, is okay. So what that tells me is I do not give this patient glutathione. Now, I might be wrong. I don't know what exactly the right thing, but we know glutathione is a double-edged sword that has the ability to hurt as well as help. And there's a lot of patients that do poorly on glutathione. I think this is at least part of it or a good chunk of it. And it does change the way I treat. And yes, I've gotten better results with these patients not giving them glutathione. Acutely, sometimes I will give it in an IV, but it's so short-lived that I don't worry about it. It's more things like chronic glutathione liposomals or creams or high-dose N-acetylcysteine that I'll avoid. Here's her Lyme test. It's positive. 90-day plan. I'm a big SIBO, FODMAP, killing off the bad biome thing. I think it's just a modern version of what naturopaths have been doing for a long time and holistic docs. We did do the botanicals and silver in order to bring down Lyme numbers. Now this is where it changes. In the morning and at noon, 200 milligrams of ubiquinol. No true. Now I know ubiquinol is an antioxidant, you're right, but that's not what we're using it for. We're using it to boost mitochondrial function. Mitochondria tend to heal over time when you use ubiquinol. You don't replace it. So what we have found is if you give somebody thyroid or testosterone, their own organs don't make as much. But if you give them, so you worry if you give them too much CoQ10 that their mitochondria will ramp down. No, we haven't seen it. Not in really sick mitochondria. I do believe with people who are very, very healthy should never take CoQ10 preventatively, though. I do believe people that have healthy CoQ10 and healthy mitochondria should not be taking CoQ10 just to prevent. It's too tricky. But this person, 200 in the morning and 200 noon, and then I used a simple resveratrol combination at dinner and bedtime. So when the body's done making neurotransmitters, done with the sex hormones and all that, then I'll start to quell it, but I prefer to use some resveratrol. It's sort of a secondary effect. It stimulates the body's own antioxidant system a little bit. Vitamin C, dinner and bedtime to get the water soluble. I use an additional combination fat soluble antioxidant. It's A, D, E, K, beta carotene, K2 combination. So I did use antioxidants in higher amounts at dinner and at bedtime, but not in the morning. And that's what changes with the SOD2 problem. And again, none of this is worth anything if we don't change our treatment from it. 90 days later, her neurotransmitters got somewhat better. We're getting all of these things and some of these things in actual normal ranges here. When we look at the mitochondrial activity, it returned to normal. Now that's really neat. And did we have symptom reduction? Yes. Depression lifted, palpitations minimal, joint pain improved over 50%, fatigue is a little better. Sleep improved 4 to 6 hours a night. Now look, I didn't cure all of her Lyme systems in 90 days, but I will take this result all day. And she's not on antibiotics anymore. She will use the botanical and silver options that you've seen. Sex drive returned, including she asked for a prescription for her partner for Viagra. I think those are good signs. It's all about sex, right? Because that's just what I keep talking about today.